Welcome to the IDEXX Continuing Education Series.
Well, hello and welcome to our webinar today. It's another one in the IDEXX Continuing Education Series that we're running at the moment. The one this afternoon is going to have a focus on our Catalyst chemistry analyzer. This includes both the Catalyst one and the Catalyst EX. And it's a platform that we've had in place for a few years now, but it's one that we have the ability to keep adding to. You know, it's one thing. So we're going to talk about sort of these 8 new tests in 8 years that have become available on the Catalyst, and you can see the list of them there with that. You know, with electrolytes, phenobarbital, total T4, fructosamine, C-reactive protein, IDEXX SDMA, progesterone, and soon to be bile acids on the Catalyst. I think this is a reflection of, the focus that IDEXX laboratories have on research and development. It's in the order of $100 million a year plus that they're putting into research and development. And with the Catalyst, you've got an analyzer that will grow with you in time and have, an increasing and expanding menu that, can all be sorted out through, just with a software upgrade. So, it's got technology for life with that, we can keep adding things onto that. So I thought we'd just run through some of those, some of them have been around for a few years now, but look at these extra tests that are added, just to sort of have a run through what their utility is to you in clinical practice. We'll start with electrolytes. And I guess when we start talking about these, people often take themselves back to physiology in 2nd or 3rd year of vet school. And that sometimes gives you the heebie-jeebies. But remember that, when we look at the fluid in the cells compared to outside the cells, they have a very different electrolyte balance. So you can see in the extracellular fluid, the primary cation is sodium, primary anion is chloride, a reasonable amount of bicarb, some calcium, but the levels of magnesium and potassium and phosphate and things are very much lower in the extracellular fluid. Whereas in the intracellular fluid, we have, primarily there's a lot of potassium, magnesium, and more of the sort of phosphates in there. So it's, there's a significant difference between those, and we need to keep that balance to have healthy functioning cell membranes with that. So when we get changes in electrolytes, it's going to help us manage, by knowing what those are, it can help us manage those patients appropriately. When we look at sodium to start with, probably the primary thing that's affecting the sodium concentration is water balance. The amount of sodium in the body can certainly change, which may change the sodium concentration, but water balance is going to play a huge role in that. And the sodium concentration we have is really a reflection of how much water we have relative to the sodium in the extracellular fluid. Now, sodium is important because it has a significant effect on osmolality and also affects circulating volume. So if sodium gets very low, typically, we can have problems with circulating volume as well. If we think of hypernatremia, sometimes that can be associated with hypovolemia with that. So we've lost fluid relative to sodium with that. So that can be because we are losing fluid that's got some sodium in it, but relatively more water. So that can be with, things like vomiting or diarrhea, kidney disease, with significant cutaneous disease where we're losing fluid that way, or even third space losses. There are some situations where we're losing primarily water. So diabetes insipidus, where there's significant loss of water through the kidneys, insensible losses, but it can also be the result of reduced intake with that. Probably less common is a direct increase in sodium intake. It can be oral, occasionally with things like animals getting exposure to salt licks or significant salt in their food. Can be parenteral with things like, ongoing high sodium fluids, but in the scheme of things, probably less common. Hyperaldosteronism can sometimes be a cause. We see it occasionally where, there's an adrenal mass or secondary to increased renin production where we get increased aldosterone. So remember, in the distal tubule in the kidney, that's going to cause sodium resorption and potassium excretion with that. And these patients may present with things like hypertension and stuff as a result of that. When we think about hyponatremia, the patient can vary with their volume in this setting. We sometimes have patients that are hypovolemic associated with hyponatremia. So they are losing sodium in excess of the fluid that's being lost. So that can be, again, gastrointestinal kidney disease. Addison's disease is a potential cause of that. Sometimes it can be a normovolemic hyponatremia. So if a patient's been given hypotonic fluids, they're just getting less sodium with that, or with things like psychogenic polydipsia. Sometimes we'll see it associated with an increase in volume. So sometimes with significant liver disease, congestive heart failure. So we're getting, stimulation of the renin and angiotensin aldosterone system. You're trying to retain fluid to increase circulating volume to try and improve heart function. And sometimes acute kidney injury where they're oliguric or anuric, or in really end-stage renal failure where they're becoming oliguric or anuric, that can happen. Sometimes we can also see it with situations where there's increased osmolality, so with diabetes mellitus or mannitol infusions, where those substances draw more fluid into the circulation, so just dilute the sodium out. And sometimes pseudo-hyponatremia, so hyperlipidemia and things like that, will just the sodium truly hasn't changed, but those things will just affect the way the measurement you get of the sodium. When we look at chloride, it's the most prevalent anion in the extracellular fluid and the most prevalent anion in the glomerular filtrate. There's significant amounts of chloride in gastric fluid, so the stomach is secreting a lot of hydrogen ions, chloride and potassium. So it's got relatively more chloride there. Important to remember that, if you think about the normal electrolytes we've got, sodium might be in the order of 145 to 150 or so. Chlorides are more down 105, 110 with that. So there's more sodium in the extracellular fluid than there is chloride. So if you're losing or gaining equal amounts of sodium and chloride, that's going to interfere with the balance between sodium and chloride. So for example, if you've got a patient on 0.9% sodium and chloride for a prolonged period of time fluid-wise, that's going to push the chloride relatively higher than it will the sodium as a consequence of that. So sometimes we'll see hyperchloremia where, say for example with diarrhea, where we're losing relatively more sodium than chloride. So that makes the chloride seem relatively higher with that in circulation. We sometimes get situations where there's increased chloride intake. So as I said, ongoing supplementation with 0.9% sodium chloride, hypertonic saline, salt supplementation, or even things like ammonium chloride. Sometimes we will get chloride retention and it can be affected by acid-base status with that. The other time where it looks like the chloride's really high is in patients, and usually it's only going to be dogs because cats don't do well with potassium bromide. But in dogs that are on potassium bromide as an anticonvulsant, the bromide can be measured as chloride by different techniques. So it makes the chloride look really high with that, but it's actually just the bromide being measured there as well. When we look at hypochloremia, obviously, losing more chloride than sodium. And one of the typical situations with that is going to be with loss of just gastric contents. So gastric outflow obstruction, a motility disorder, or potentially even, patients with a gastric dilation volvulus, even though that fluid accumulating in their stomach is still inside the body, it's been lost from circulation with that. Diuretics can cause greater loss of chloride than sodium, and sometimes it can be a result of acid-base abnormalities as well. When we look at potassium, it's our major intracellular cation, and with sodium has a role in membrane function, so like action potentials forming and things like that. It's usually derived from the diet, but when old cells break down, potassium comes from there as well. It's primarily excreted through the kidneys, a little bit through the gut. It can shift between the extracellular fluid and the intracellular fluid. So things like acid-base abnormalities can affect it. So if you've got a patient that's acidotic, as the hydrogen ions move into the cells, potassium can come out. The opposite with an alkalosis. Insulin tends to drive potassium into cells. So if you've got, we may exploit that in a patient with a severe hyperkalemia, but sometimes when you're treating say a diabetic ketoacidotic animal with, say, an intravenous insulin infusion, we've got to monitor the potassium closely because sometimes it will drop as a result of that. With tumor lysis syndrome, so, with chemotherapy with some cancers, with all that cell death, they can become hyperkalemic with that. And compared to the other electrolytes, the potassium's kept in a much narrower range than some of the other electrolytes. So when we think of causes of hyperkalemia, urinary retention, so a ruptured urinary tract, so leaking ureter, leaking bladder, or urethral obstructions, so you're retaining urine with that. In some patients with acute kidney injury, it will occur. Gastrointestinal disease can be a cause, and one of the classic things with that is whipworm infections. They can sometimes have electrolytes that look remarkably like a hypoadrenocorticoid dog with that. So keep that in mind. Addison's can obviously cause it too. It can be with translocation. So as we said, lack of insulin or acidosis. So potassium comes out of cells. It's pretty uncommon to have an intake of it so high that's going to cause a hypokalemia. And sometimes we get a false elevation in potassium levels. So platelets have a reasonable amount of potassium in them. So if you have a patient with a significant thrombocytosis, sometimes on a serum sample, you will find hypokalemia, but it's a result of the platelets. If you repeat that potassium level on a plasma sample, so the platelets haven't been activated, it will usually be normal. There are some breeds of dog, like Japanese Akitas, Shiba Inus, some Shar-Peis, that are naturally microcytic, so they run at a lower MCV, but they can sometimes have quite a bit of potassium in their red cells. So if the sample's hemolyzed, it can cause a false elevation in the potassium. If we think of hypokalemia, often patients that are PUPD, you're going to lose a certain amount of potassium in urine. So if you're PUPD, that can happen. So chronic kidney disease, some diabetics and things like that can occur with, vomiting or diarrhea. As we discussed before, patients with excess aldosterone, they're going to be losing potassium through their kidneys because more of it's being excreted in the distal tubule. Can occur with those transcellular shifts again. Reduced intake, so animals that are inappetent, it can sometimes occur. And I've got iatrogenic there on the list because patients on fluid therapy that aren't being appropriately supplemented with potassium can become hypokalemic. We'll just run through a quick case study here to sort of look at the value of the electrolytes. So this is King, an 8-month-old male neutered German Shepherd who was presented for vomiting. He'd been vomiting for a couple of days. The day before presentation, even though he was occasionally vomiting, he still seemed pretty bright. But the morning of presentation, the vomiting had gotten worse and he'd vomited every time he drank. He brought up some water, brought the water up. He didn't want to eat and he was becoming very dull, which is not expected in an 8-month-old puppy. So on his physical exam, temperature was okay. He was a little tachycardic and tachypnic. His mucous membranes were dry. So clinical indications along with skin turgor that he was dehydrated. He was very dull. He just wanted to lay there. When you palpated his abdomen, couldn't palpate any obvious foreign bodies or anything like that, but he did vomit up some white froth while abdominal palpation was occurring. So obviously in this dog, we're worried with, probably the most specific problem we've got here is his vomiting. So it makes us worry about gastrointestinal disease. That could be primary. So, in a puppy, foreign body, dietary indiscretion, maybe something infectious. Could be secondary to something metabolic, Addison's or kidneys or liver or things like that. So our plan was with him to start off with some blood work to see what we found, to look for metabolic causes. His hematology, there was signs of, potentially stress leukogram there with the mild neutrophilia and the lymphopenia and the monocytosis. A blood film review didn't show any signs of left shift or toxic changes or anything like that. So maybe a little bit of inflammation, but certainly stress is quite possible. When we looked at his chemistry, he had a mild increase in urea in a dehydrated dog. That's most likely pre-renal, especially when you look at his urine-specific gravity. The alkaline phosphatase is probably age-related in an 8-month-old dog that's still growing. Creatinine's normal, so makes us a little bit more comfortable about his kidney function. This patient I saw in the days before SDMA. When you look at his electrolytes, sodium and chloride tend to behave the same way. So if sodium's normal, chloride should be normal. If sodium's low, chloride should be low. If sodium's high, chloride should be high. And in this dog, we've got quite the disparity. So we've got a it's in the lower range, but a normal sodium and a pretty significantly reduced chloride with that. And you'll notice that the bicarb is elevated. He's also reasonably hypokalemic. So what we were worried about in this dog was a gastric outflow obstruction with this, because when you vomit, you lose hydrogen ions, you lose chloride, you lose potassium. Patient's dehydrated, so in the kidneys want to resorb fluid, so they resorb sodium in the proximal tubule. Normally chloride would come with that to maintain electrical neutrality, but in the case where the chloride's low, they're probably going to resorb bicarb instead. Then down in the distal tubule, under the influence of aldosterone, also trying to save fluid, you'll get sodium resorption and potassium excretion. But in this case, the potassium is quite low. So the body will get water, carbon dioxide, make a carbonic acid, the H2CO3, break off a hydrogen ion to exchange for the sodium, so that they can resorb the sodium. And guess what? You've made another bicarb. So that's why the bicarb's high, because they're excreting hydrogen ions in exchange for the sodium. That's why we've got acidic urine, even in the face of a patient that's likely got a metabolic alkalosis with that high bicarbonate. So we thought this dog had a gastric outflow obstruction. With imaging, that was confirmed. So the dog ended up having an exploratory laparotomy to remove some material that was well and truly jammed in his pylorus with that. So, in this case, the electrolytes were really quite helpful to give us some direction. So I guess when are we going to use electrolytes? Obviously it's part of just routine screening of patients, wellness studies, preventive care, pre-GA screens, things like that. And we're obviously going to use them in unwell patients, with vomiting, diarrhea, diabetes, kidney disease, because we need to know what changes there are in those electrolytes, so that we can determine how we need to treat them with fluids, like what type of fluid, do we need to be supplementing potassium and things like that. Obviously, if we've got patients in hospital on fluids, diabetics, diabetic ketoacidotic, on fluids and insulin and things like that, kidney failure patients, we need to be monitoring their electrolytes routinely, at least every day, so that we know, do we need to change their fluid therapy with that, or change the, things like potassium supplementation or the type of fluid. The next test that came out with Catalyst was phenobarbital. we won't spend a whole lot of time on that, but obviously we have a few potential indications for monitoring phenobarbital levels. It can certainly be part of routine monitoring. When they're first started on the phenobarbital, you may check levels, at set periods after that to try and see whether we've got the level in the therapeutic range with that. Some people then do monitoring, every 6 to 12 months. Um, you know, uh, Two schools of thought. Some people do, some people don't. I think either is fine. Obviously, we want to be checking their liver enzymes with that. But the times we really need to be looking at phenobarbital levels are in patients that have poor seizure control. If you have a patient presenting to you with cluster seizures or in status epilepticus, it's nice to be able to get a phenobarbital level quickly, to determine, is their seizure control, poor seizure control, that they just don't have adequate blood levels, or is there something else going on? Obviously, if we're seeing signs of adverse effects of the phenobarbital, so excessive sedation and things like that, can also be helpful to measure the levels. And in that case, if we're finding that we're having to get phenobarbital to a level that's elevated and is causing adverse effects to control the seizures, that would be a time that we would consider adding another medication in there to try and help with seizure control. If we look at total T4, again, not going to spend a whole lot of time on this, but, I think because, I'm sure you all manage a lot of patients with thyroid disease. I guess for me, the indications in dogs are, I tend to be more someone who measures T4 in dogs if I think I need to. So, in patients that are showing clinical signs of hypothyroidism, so dullness, weight gain, cutaneous changes, they can have some lipid issues and things with that. So, there are the clinical signs we can sometimes see, occasionally neurologic signs and stuff like that. Or if you've done, a screen on a patient that's, maybe just not quite right. It's got a mild non-regenerative anemia. It's hypercholesterolemic, maybe some subtle elevations in liver enzymes. Then I think it's very reasonable to measure a total T4. Obviously, in cats, we're looking at hyperthyroidism. So, we all know those clinical signs of behavioural signs, weight loss, polyphagia, gastrointestinal signs, potentially heart murmurs, arrhythmias, respiratory signs, all that sort of thing. So, and to be honest, in cats, once they're getting past 7 or 8 years of age, it's a very reasonable thing to be including as a routine if you're doing, bloods on them. And potentially for me, even, in cats that are getting a little bit older, including it as part of your pre-anesthetic screening, just because, a subclinical hypothyroid cat can potentially have some degree of heart disease that may affect anesthesia and their sensitivity to fluid therapy and things like that. So it's a reasonable thing to know before. Obviously, in dogs, if we have a low total T4, that can be the result of non-thyroidal illness or true hypothyroidism. So in that setting, if we've got clinical signs and a low T4, doing a free T4 and TSH is a reasonable thing to do. In cats, a lot of the time, the total T4 will give us an answer. But keep in mind, cats can get non-thyroidal illness as well. So if it's a hypothyroid cat with significant other disease, or even a hypothyroid cat that is having complications as a result of its thyroid disease, it can make the total T4 drop. So you will sometimes have hypothyroid cats with, T4s in the upper end of the reference interval, but they are still within the range. So repeating the T4, looking at a free T4 can be helpful with that. But in both cats and dogs, always really important to relate the T4 to clinical signs. When we're monitoring therapy for patients in a hypothyroid dog on supplementation, we can either do trough or post-pill levels. A trough level, if it's in the mid-range or above, that's probably fine. If it's post-pill levels, we want it high range or a little bit above the reference interval. but you always want to relate it to clinical signs. Are the clinical signs that you were treating them for that you thought were from the thyroid disease, have they resolved or not? If they've had a well-controlled total T4 and it's 3 or 4 months down the track and none of those clinical signs have resolved, we have to question if hypothyroidism was the hypothyroidism, sorry, was the cause of those signs. In cats, we want to, get that T4 back into the reference interval. Sometimes after things like I131 therapy, it can get a little bit lower. Oftentimes that's not causing many issues at all. But if the cat is lethargic, looks like it's got, looks like it potentially could be hypothyroid, sometimes looking at a TSH in that setting can be helpful, because if it's getting elevated, the cat may truly be hypothyroid in that setting post-therapy. The next one that came along was fructosamine. Obviously, fructosamine is a protein complex, so it's albumin primarily that's been bound to glucose, and that then we get fructosamine from that. Albumin's half-life is in the order of 2 weeks or so in the circulation. So looking at the fructosamine can give us some indication of what the average blood glucose has been over those previous couple of weeks. It's not something I use very often in dogs, because most often in dogs, if we're trying to diagnose diabetes, if we've got clinical signs, they're hypoglycemic and they're glucosuric, we're usually pretty comfortable making the diagnosis. Obviously, cats can be more challenging with that. So, if the cat is stressed, they can, stress coming in the car, stress in the clinic, they can be hypoglycemic and potentially have some glucosuria. If it's an unwell cat, it can be, and they've got hypoglycemia and glucosuria, it can be a little harder to know, is it stress from the illness or is the diabetes contributing? So you certainly don't need to necessarily be doing it on every cat, but on some of those ones where it is unclear, it can give us a sense of, has that elevation in glucose been persistent or not? There are some cats, we've obviously got, for monitoring cats with their diabetes, clinical signs are very important. Doing glucose curves, we now have the sort of continuous glucose monitoring devices and things like that. But, in some cats that are, get anxious when blood's collected, even if it's being done at home by the owners, fructosamine may play a role in the management of diabetes in that setting. But again, always relating that to clinical signs. A couple of years ago, probably a couple of years ago now, I think I'm losing track of time, C-reactive protein became available on the Catalyst. We are very much looking at a test for dogs here. So C-reactive protein is an acute phase protein. So what happens when we get systemic inflammation in a dog, cytokines get produced, they act in the liver to stimulate the production of these acute phase proteins. There's a range of them in the body, but one of them is C-reactive protein. So it can go up before white cell counts will change with inflammatory disease. It can come down as inflammation resolves before white cell counts will. So we can use it as a marker of systemic inflammation. So when can it be useful for us? I tend to think of sort of 3 main settings that we can employ it. First of all, if you get that dog that comes in that's just not feeling well, you get the history, do the physical, they're not right, but it's not obvious as to what's causing it. You've done a CBC and a chemistry and a urine on them, and there's maybe not remarkable changes with that. Consider running a CRP. Normal is less than 10. Suspicious is in that 10 to 30 range. If it's over 30, we have significant systemic inflammation going on. So it can give us a clue that we need to pursue that patient further to look for that focus of inflammation. It doesn't tell us where it is, but it tells us it's there. We can sometimes use it in, say, hospitalised patients or patients we're monitoring to see, is inflammation getting worse? So, for example, a pancreatitis patient in hospital that you've got, that you're managing all the right ways with analgesics and fluids and nutritional support and things like that, and they just don't seem to be improving. Doing serial monitoring of CRP can give us an idea. If it's climbing and we can have results in less than 15 minutes with that, it's going to tell us that that inflammatory disease is getting worse with that. The other time we can use it is monitoring response to therapy. There are some diseases, inflammatory diseases that we have, that it's not necessarily straightforward to get samples to objectively monitor them again. Say, for example, a patient with immune-mediated polyarthritis. We'll put them on immunosuppressive therapy. We'll have them on that for a few weeks. They seem to be doing well. So we make the decision to start tapering the therapy. Most of them are probably going to be fine with that, but I'm sure you've probably all encountered patients that, within a week of you tapering the treatment, the client's back and says, they're limping again, they're not feeling well. And that's frustrating because then we have to go back up to a high dose of therapy again. We could look, if we had a baseline on that patient, we can look at CRP in that setting. If the CRP's come back to normal, I would be pretty comfortable to taper that prednisolone. If the CRP is still elevated, I'm not going to taper it at that stage. There was a paper published a few years ago in Journal of Veterinary Internal Medicine where they looked at a group of patients with bacterial pneumonia. Some they treated for a set duration of therapy. Others they monitored C-reactive protein. When it got back down to normal, they treated them for a little bit longer and then stopped the therapy. The dogs that had the therapy guided with CRP had a significantly shorter duration of antimicrobial therapy. That's good for antimicrobial stewardship. We only want to use antibiotics for as long as we need them. The good news is there was no difference in the rate of relapse between those two groups. So having that shorter duration of antibiotic therapy did not make those patients more likely to have a recurrence. So it's a useful test to have in the clinic when we're looking at dogs, as I say, to either determine if they have inflammatory disease, determine severity over the course of time, and monitoring the response to therapy in certain diseases. But remember, just for dogs. We'll move on to SDMA, and obviously this was one of those tests that had been available in the reference laboratory for a little while before it became available in the Catalyst. But having this as a real-time care option, is very useful for us in practice. So SDMA, symmetric dimethyl arginine. So it's arginine is an essential amino acid in the diet. It gets used in intranuclear metabolism in all cells, and it gets methylated as part of that process. And one of the byproducts of that is SDMA. The SDMA just hangs out in the cell until that cell dies. There is always cell turnover in the body every day, so we have a steady SDMA production. It's almost exclusively excreted by glomerular filtration without significant tubular resorption. So it's a really nice marker of glomerular filtration rate. We have other markers of GFR. So creatinine is probably non-invasive measurements of GFR. We can do techniques to specifically measure that, giving them an agent, monitoring its level, and over a course of hours, and then we can get GFR measured. But it's not easily accessible to have that done, and it gets expensive. So we use these surrogate markers of GFR like SDMA and creatinine. So creatinine served us well for a number of years. Why use SDMA in combination with it? What are the advantages? So first of all, SDMA is more tightly adhered to the glomerular filtration rate than creatinine is. Creatinine has its challenges in that early on, as GFR drops, reasonably significant changes in GFR cause very small changes in creatinine. As kidney failure gets more advanced, small changes in GFR cause large changes in creatinine. So later in the course of kidney disease, it'll give us information, but early on, not so much. Second thing is that remember back in physiology at vet school, and these are very arbitrary numbers, but you lose concentrating ability with around 2/3 loss of kidney function, and azotemia develops at around about 3/4 loss of kidney function. So they're relatively late stage markers. STMA can go up as early as 25% loss of kidney function or GFR, reliably at 40%. So it goes up significantly earlier with that, which is useful for us. The third difference is we know that creatinine is a breakdown product of muscle. So as muscle's turning over every day, we get creatinine production. So creatinine can be influenced by lean body mass. So sometimes, and we're talking primarily dogs here, we have some breeds of dogs that are naturally heavily muscled. So greyhounds, things like American Staffies and such. So they may have a creatinine that's a little bit above the reference interval, but that's okay for them because that's just where it runs at. At the other end of the scale, we can have patients that are in lean body condition. So for example, a dog with hyperadrenocorticism, and some of them, the muscle just falls off them. The creatinine may be quite low, even though their glomerular filtration rate might be reduced. A hypothyroid cat, a cat with kidney disease that's losing a lot of condition, its creatinine over time may not be as good an indicator of what their GFR is because it's going to be affected, the creatinine level, by that lean body mass. So in that setting, the STMA is not affected by lean body mass the way it is. So in those patients that are very lightly muscled, in those patients that are very heavily muscled, STMA is going to give us a more accurate indication of what the glomerular filtration rate is. Now, that is not in any way saying we're going to forget about measuring urea and creatinine. They're still really useful markers for us. So we use STMA with those. We use STMA in concert with doing a full urinalysis. We need all of that information together, potentially things like UPC ratios. All of that information together is giving us the best information we can get about a patient's kidney function. So, we can use STMA in patients that we're worried about kidney disease, that we're monitoring kidney disease, but we can use it in patients that have PUPD. I'm sure you've all encountered, a dog or a cat that's drinking more and peeing more. You do a urinalysis, they're not concentrating their urine, but there's not an obvious cause for their PUPD on that. You do a CBC in chemistry, and there is not an obvious cause for the PUPD there. And there's always that question of, could you have a patient that's between that 2/3 and 3/4 loss of kidney function, and that's what they've got, kidney disease causing PUPD, but they're not yet azotemic. STMA is going to help you in that setting. If the STMA is normal, it's not going to be kidney disease causing it, whereas if it's elevated, we need to be considering that possibility. But realistically, where STMA has a huge use is in things like pre-anesthetic screening, in preventive care and wellness and senior screening. Because we're trying to pick up kidney disease earlier, we can potentially detect patients with stage 1, IRIS stage 1, chronic kidney disease with STMA. And these are patients that are going to be asymptomatic, likely with it. So that's where it really comes into its own with its usefulness. So we have an algorithm, obviously, it's interpreting the STMA is easy in a patient that's, azotemic, isostonuric, and it's got a high STMA. Guess what? We know it's got kidney disease. But probably the ones that cause more challenge are the ones where the STMA is mildly elevated in that 15 to 19 range, and everything else is okay. And you've got a patient that seems clinically well. We don't want to miss that opportunity. You don't want to just be like, oh, and remember, it's a marker of GFR, not a marker of chronic kidney disease. So we don't want to automatically go, oh, well, the STMA is up a bit. They've probably got CKD. Let's send them home with a bag of kidney food. But we also don't want to be like, oh, well, we can just not worry about it. So, if you've got that mildly increased STMA, review the history and physical exam. Are there any other markers of kidney disease? Do a complete urinalysis. If that's all normal, what I would suggest is we get that patient back in 2 to 4 weeks' time, recheck the creatinine STMA, recheck the urine. If it's persistently elevated, then we likely have a patient that's got reduced glomerular filtration rate. So we can do an investigation to look for a cause, do that full urinalysis, check their blood pressure, do a urine protein creatinine ratio, potentially do a urine culture if you think it's indicated, potentially, do some imaging, check for infectious diseases if you think that's appropriate, maybe check a T4 in a cat. Even if we don't find a cause for that, and if we find a cause, that's great because we can try and treat it and then reduce the severity of the disease. Even if we can't, we can take some simple steps to try and keep them well. Make sure they have free access to water all the time. Make sure they're on a good quality diet. Be careful with nephrotoxic drugs. That doesn't mean they can't have them, but try and use, like if it's a non-steroidal, try and use the lowest dose you can. Monitor them carefully. If they're going to be anaesthetised, make sure we have them hydrated and monitor their blood pressure during the procedure. And if we know they've got stage 1 kidney disease, we're probably going to monitor them more frequently than if they didn't. IRIS, so the International Renal Interest Society, has endorsed IDEXX STMA. There are some different STMA assays out there. The methodology that IDEXX uses has been shown to be reliable and consistent with that. So, in the past, to try and diagnose stage 1 kidney disease, you could look for creatinine increasing within the reference interval. Using things like VetConnect Plus was great for that. Persistently dilute urine or persistent proteinuria, finding abnormal kidneys on imaging. But unless you were doing those tests for another reason, you weren't going to detect it because they're usually asymptomatic. So by detecting a high STMA and demonstrating it's persistent, we can say that they've got stage 1 disease. And recently, IRIS updated their staging scheme so that it's got STMA in that staging scheme. I won't go into it anymore now because we're going to have another one in the education series talking about those IRIS staging and all that sort of thing with STMA. So you can have a listen to that one. One that came out a little more recently was progesterone. I'm an internist, not a theriogenologist, so I am not going to, try and give you the impression that I'm a reproductive expert by any means. But, the main time we're going to use progesterone is in when we're trying to predict times of mating with that. So what you're looking for is doing serial monitoring over, in later proestrus to try and determine when you get that first sharp and sustained increase in progesterone, because that usually relates to the LH surge. Then ovulation happens a set time after that, and then their breeding times are related to that time of ovulation. One thing I would say to you about measuring progesterone is it can be fiddly. Lots of different things can affect it. Sample quality, time of the day, sample type, all that sort of thing. And different methodologies, you can get different numbers with it. So what I would suggest is if you're going to be using progesterone to predict times of mating, use the same method the whole time so we don't get variations in number because of that. Sample them at the same time of the day. Try and have them, if we're doing it in the morning, try and have them fasted, because things like hemolysis and lipemia can affect the result. Keep a consistent sample type. Use heparin all the time or use serum all the time, because if we're changing times and feeding and methods and all that sort of thing, it's going to cause different numbers with the results. So really important that we stay consistent with that. Finally, I'm going to touch on bile acids because very soon they are going to be available on the Catalyst. I guess the things I wanted to raise with bile acids, we need to look at liver enzymes and bile acids differently. Liver enzymes tell us about particular things in the liver. So ALT or alanine aminotransferase is this enzyme that lives in the cytosol of the cell. You damage a hepatocyte, it can leak out. AST does the same. AST is a little bit less specific though, because it can come from muscle. So generally, ALT is telling us about damage to the liver cells. Alkaline phosphatase is an induced enzyme. It's in the cell, but it can be induced by production. The hepatocytes can be induced by cholestasis. So, whilst the hepatocytes produce bilirubin, they don't like swimming in it. So, if we have cholestasis, that's going to induce the production of alkaline phosphatase. It can also go up in dogs with glucocorticoids, not in cats, or it can go up with bone growth or remodeling. GGT is an enzyme, gamma glutamyl transferase, comes from the biliary epithelium, so it can go up with cholestasis as well. So those liver enzymes are telling us about hepatocellular damage and cholestasis. They don't tell us anything about function. We can have animals with normal liver enzymes that have great liver function, animals with high liver enzymes that have poor liver function. But we can also have animals with normal liver enzymes that have poor function, or we can have animals with high liver enzymes that their function is still okay. The liver has a remarkable capacity. You've got to lose probably over 70% of the functional tissue before liver function gets affected. So liver enzymes tell us about damage or cholestasis. Bile acids tell us about function. So what we're doing with those is they get produced in the liver, they go into the gallbladder, and when you eat, you get gallbladder contraction. And so the bile acids, along with the bilirubin, get into the gut, where they help with fat absorption. They micellize the fat, so they sort of surround it, so it can get absorbed across the gut, primarily in the ileum. So then, those bile acids with the fat come back down the portal vein, the liver extracts them from that portal circulation. So whilst we might get a little bit of an increase in bile acids postprandially, it shouldn't be significant. But with the postprandial test, we're putting more pressure on the system. So we're trying to determine, is the circulation in the liver reasonable, and do we have enough hepatocytes that are functioning normally? So reasons bile acids can go up. If we have dysfunctional hepatocytes or we've lost hepatocytes, bile acids will go up because they get that portal blood, they just can't do their job with it. We can get elevated bile acids with portovascular anomalies. So a shunt, so that portal blood, just not enough of it goes to the liver for the liver to extract the bile acids. Or it can be microscopic in the liver. What we used to call microvascular dysplasia is now portal hypoplasia without portal hypertension. It's just happening microscopically in the liver. Those portovascular anomalies. Bile acids can also go up to some degree with cholestasis. So we need to sort of look at the whole picture with that. Remember that, so if we, liver dysfunction can have other effects in the blood. We sometimes may see a low reticulocyte hemoglobin. We may see microcytosis. Not always, though. In the biochemistry, remember the liver produces urea, glucose, albumin, and cholesterol. So in some patients, not all, but some with liver dysfunction, they may be low. So if you might find things on your blood tests that you're like, oh, I think, or even elevated liver enzymes, that you might say, I want to be able to check liver function. So bile acids are good. The other time, remember, is clinical signs might indicate it. The clinical signs of liver disease can be vague. There might be signs of inflammation or gut upset or things like that. Liver dysfunction generally manifests in other systems. So we may get gastrointestinal signs like vomiting or diarrhea. We may get urinary tract signs. If they're forming ammonium urate crystals or stones, we may get hematuria, plaquuria, stranguria. We may get neurologic signs with it as well. So if a patient has clinical signs consistent, we want to assess liver function. So for me, in a patient that's seizuring, I want to check their liver function to see if that hepatic encephalopathy could be contributing. So if you get a very mild elevation, sometimes that can be a little harder to interpret. But if they're getting beyond 30 or 40, then we likely have liver dysfunction with that. Keep in mind, you can always, in the past we've done them in the lab, you could do them on the snapshot, with snap tests, but they had a pretty narrow range on what they could measure, only up to about 30, whereas the range on the catalyst test will be 1 to 180, so the same range as in the lab. So why would you want to do this in real time? Well, I guess if you've got a patient you're doing a pre-anesthetic screen on that you're worried about liver function, being able to do those, get that bile acid result in 15 minutes makes a difference. If you have a patient that comes in that's acutely seizuring or acutely hypoglycemic, it's nice to have those results in real time in about 15 minutes. The time to not run bile acids is in patients that are icteric. Bile acids go down the same pathway as bilirubin. So guess what? If they're icteric, the bile acids are almost certainly going to be high unless it's a prehepatic icterus. And guess what? We can work that out by doing a CBC. So let's not do them in patients that are icteric. So that's about what we've got today. So if there are any questions, please jump in and let me know. But just, to review, we've looked at the sort of 8 tests, 8 tests in 8 years that have been added to the Catalyst platform. So we've run through those. So these are a result of the, research and development that IDEXX put into these sort of things. So, it's that technology for life, allowing you to do more in real time. And guess what? With this commitment to R&D, there are almost certainly going to be more tests in the future that are going to be available to run on your Catalyst. So it's that menu is going to keep expanding in time. If you have any questions, please don't hesitate. You can always reach out to me through the phone or via email at IDEXX, and happy to answer any questions for you. So thank you for having a listen today, and we'll see you soon for another one of the CE webinars. Thank you very much.